Our final subject in this edition of ACCEL features Dr. Sidney Smith with Dr. Arthur Agatston from the University of Miami, who discussed the role of the Mediterranean diet on cardiovascular disease.
Welcome to ACCEL.
Great to be with you, Sid.
Now, diet is in front of us all the time now, and everybody has a different recommendation, a different solution. What led you to focus on the Mediterranean diet?
For one thing, we've been through a horrible experiment in the last 30 years in this country. We're doing a diet that's unprecedented in history. And I think we have to follow a more traditional diet, of which there are many that don't lead to chronic disease. The Mediterranean diet has the most data, and it's the most palatable. So that's the one that I think is the answer for Western population.
And this goes back to ACCEL Keys. So tell us a little bit about the history here.
Sure. Well, after World War II, ACCEL Keys did the famous 7 countries study where he looked at high-fat countries, Northern European countries, and less industrialized world, and concluded that high fat meant higher cholesterol, more heart attacks, and low fat was better. He did also study Greece, which was an exception. It was relatively high fat, but very low in heart disease and other chronic illnesses. And while we often adopted the main point that high fat was bad and high carb was good, there was this important exception. And what it comes down to is really what the fats and carbs and protein are made up of. The Mediterranean diet has elements that appear to be protective, including some of the fat.
We've gotten into and looking at diets. Mediterranean diets vary, at least a Mediterranean style, but what are the basic components there? I mean, when you work with patients that want to switch to a Mediterranean style diet, what are the things you have them focus on?
The most common is probably more use of good oils, particularly olive oil. The virgin or extra virgin olive oil is an advantage. Whenever we're talking about these foods, they're sort of good, bad, and in between. So olive oil, but they emphasize fruits and vegetables, low-fat dairy, having fish several times a week, poultry, low in red meat. Nuts and legumes are part of it also. And they all don't like red meat. So red meat is really low across the Mediterranean. Depending on the studies and looking at mechanisms of action, all the individual components have pretty positive data behind them.
How do you see, in terms of staying with, let's say, secondary prevention, what data do we have to suggest that the Mediterranean diet may be efficacious? Patients that's had a myocardial infarction, wants to change their life, they're going to stop smoking. They say, what about diet?
The original large study, and it's somewhat controversial, the first really good fat study was the Lyon heart trial with about 400 individuals, and that was secondary prevention. It was all people who had myocardial infarctions. And there was a 2-year follow-up they reported initially, and then a 4-year follow-up presented in 99. And it was actually 14 patients in the Mediterranean intervention group who had cardiac events versus 44 in the control group. And that was very impressive. Since then, there are multi-center studies that have been done in Greece. A lot of these studies have been done in Europe in secondary prevention with also quite impressive results.
In terms of reducing recurrent myocardial infarction, that would be one outcome. Mortality?
Total mortality as well. The biggest study is the Nurses' Health Trial from the Harvard School of Public Health with 75,000 nurses that they followed for 20 years. And those who had the closest adherence to the Mediterranean diet principles had less death as well as less myocardial infarction.
So are you including the Mediterranean diet in your cardiac rehab or in your work with patients after events?
Absolutely. Most of the argument has been, of course, between low fat, high carb, and a higher fat diet. We certainly don't encourage saturated fat or processed fat, hydrogenated oils, but olive oil looks very, very good with all the antioxidants, and so does omega-3 and the combination. And of course, those oils, they're cooking oils, but you get them in fish and nuts, and fruits and vegetables as well have some good fat.
Do you think that shifting towards primary prevention, have you experience on adherence with the secondary prevention? Patients that are used to an American-type diet, do you find that they can switch and stay?
The main battle there is convincing them that a diet is a lifestyle and not just something you do before an affair like a wedding to lose some weight. And for those who understand, and particularly those who like to cook, I mean, we're obviously grabbing too much food on the way home at the fast food restaurants, but the Mediterranean diet, you can have a great variety of wonderful meals, and we find people have been satisfied with it and do well over many years. When you look at the components, and by the way, moderate alcohol intake, and particularly wine and red wine, is part of it also. It's more taking the time and the understanding in cooking rather than grabbing the processed foods. That's the challenge. If they do that, they enjoy the diet.
Well, for me, I happen to like Mediterranean diet a lot, but I wonder whether someone, let's say, from Asia, I'm wondering, do you have any transcultural experience? Can you adapt the Mediterranean style diet to Asia? Do you find that there are difficulties in how different populations can adapt to a Mediterranean style diet?
Absolutely. And the record of Asians moving to this country is that they start with fast food, and they have a very high incidence of metabolic syndrome, as well as what we see in Miami, and you see at the rest of the South, that the Hispanic populations who are coming and also just have the thrifty gene. They have a high incidence of metabolic syndrome. And again, if the education is there, in the Asian diet, the principles aren't really that different. I mean, the Asian oils are pretty good, and there were a lot of studies. Okinawa had the greatest number of centenarians. And my recommendation for Mediterranean isn't an exclusion of a traditional Asian diet. It's because I think most Americans will accept that better. But if you're having whole foods and you're avoiding the processed foods, then an Asian diet can certainly be very healthy as well.
Well, one final thought in terms of the lipid panels. Do you see much improvement in surrogate measures, intermediate measures like the lipid panel?
It's interesting. In the original Leonhardt trial and in others, if you take a general population, you don't see much of a change. And in the Leonhardt trial, there was actually no change in the classic risk factors. When you're dealing with a metabolic syndrome population, which is what we're really seeing, a big percentage of our high-risk patients, in them you do see improvements. HDL does go up often significantly, and triglycerides come down.
I think that's an important point, that early on with the 7 countries, they may have been looking only at total cholesterol and totally missing the fact that although there might have been modest changes in total cholesterol, there was a significant increase in HDL, and that you really are improving the risk profile, even though it wouldn't be reflected by the total cholesterol.
Yes, the lipids are better, and measures of inflammation from HSCRP to interleukin-6 and other measures of inflammatory factors, endothelial function by flow-mediated dilatation of brachial artery, and other measures have been shown to improve with a Mediterranean diet. And it is more impressive with those with metabolic syndrome, and those, of course, the ones who have more inflammation, more endothelial dysfunction, higher triglycerides, lower HDL. In that group, there is a lot that you can measure. Years ago, a typical secondary prevention group, it would be harder to show changes in lipids.
I suppose you'd be in favor of sort of a general transition in our culture to more of a Mediterranean-style diet. And fast food is the evil player here. Makes me wonder, why can't we have fast Mediterranean diet food? I mean, we do have in Chapel Hill a restaurant known as the Mediterranean Deli. It's very popular. Do you have to fry something to do it fast?
Yeah.
Do you think it's possible to franchise a Mediterranean deli kind of experience? It would take on like McDonald's.
There is one in Miami, and there are about 6 restaurants around the city that have fresh food and very much Mediterranean. And they're struggling, although they're doing better. The other optimistic thing is when you look at young mothers, I call it the super moms. They're well educated, they're cooking on whole foods and really Mediterranean type diet. These kids do great, sometimes until they go to school and are exposed to other diets, and school is the other great opportunity. And we did a trial called the HOPS trial in Florida with kids where we changed what they were eating in the cafeteria and the education. And the good news, they accepted healthy food.
I can't thank you enough for coming to ACCEL and sharing your ideas To my way of thinking, the shifts in lifestyle are as important to our society as any recommendations about statins and aspirin. I think there has to be a fundamental commitment to the right lifestyle, and certainly these other medications are extremely important and valuable, but hopefully some of the thinking here about the Mediterranean-style diet and other healthy diets will prevail.
I think if we don't change both nutrition and exercise, the debates about what type of healthcare system we use, it's not going to matter. It's going to be overwhelmed with chronic disease. I agree 100%.
Strong point. Well, thanks very much.
Thank you.
That concludes this edition of ACCEL for February of 2012. For details about studies discussed on ACCEL, refer to the written summary included as a PDF file on this disc. This issue of ACCEL qualifies for up to 4 Category 1 CME credits. To obtain CME credit, go to www.audiodigest.org/online testing. This is Alfred Beauvais for the American College of Cardiology. Thanks for listening.